Welcome to the ASCO Guidelines episode of the ASCO University Weekly Podcast. My name is Alok Khorana, and I am a medical oncologist and professor of medicine at the Cleveland Clinic Lerner College of Medicine in Cleveland, Ohio. Today, our podcast features a discussion on an ASCO guideline that I had the privilege of authoring on potentially curable pancreatic cancer, published in the Journal of Clinical Oncology a few months ago. The purpose of this guideline is to provide evidence-based recommendations to oncologists and others on potentially curative therapy for patients with localized pancreatic cancer. Two other guidelines evaluated recommendations on locally advanced and metastatic disease, but this guideline really focused on what makes a patient potentially curable, what is the workup that needs to be done, and what is the appropriate way to proceed in terms of resection first versus neoadjuvant chemoradiation first. The guideline offered strong recommendations based on a systematic review of 9 randomized trials. Some of the key recommendations that I want to highlight in this discussion include a focus on the diagnostic workup, as well as a focus on treatment approaches. First, addressing the diagnostic workup, the guideline strongly recommends that patients undergo either a pancreatic protocol CT or an MRI to best assess the radiographic anatomic relationships of the primary tumor and for presence of intra-abdominal metastases. EUS, endoscopic ultrasonography, and or diagnostic laparoscopy may be used as supplemental studies, and a CT chest is not recommended. Simply a chest X-ray is sufficient based on some of the data that suggests low likelihood of spread to the thorax in the absence of liver metastases. Second, focusing on which patients should undergo upfront resection, the guidelines is very emphatic on doing a proper assessment of the baseline performance status and the comorbidity profile, and making sure that patients are appropriately suitable for a major abdominal operation. The guideline panel strongly recommends multidisciplinary collaboration to formulate treatment and care plans. Especially important is diagnosis and workup and resection in a high-volume center that has access to multidisciplinary input as well as to high-volume surgeons. Clinical trials should certainly be offered at every stage of treatment of pancreatic cancer. The guideline focuses very much on which patients are appropriate for resection of the primary and sets its bar at the following criteria. They can't have clinical evidence of metastatic disease, that's pretty obvious. They should have a decent performance status and comorbidity profile. No interface between the primary tumor and mesenteric vasculature, and a CA-99 level in the absence of jaundice that is suggestive of potentially curable disease. In other words, it provides clinicians some degree of flexibility in determining resectability in a multidisciplinary context. If patients are not appropriate for upfront resection, preoperative therapy is recommended, particularly for patients who have radiographic findings that are suspicious but not diagnostic for extrapancreatic disease, or a performance status comorbidity profile that is not appropriate for a major abdominal operation, although it could improve over the next few weeks to months, or a CA-99 level that's suggestive of disseminated disease, even if such disease is not documented on imaging studies. If preoperative therapy is administered, the panel did recommend a complete restaging evaluation after completion of treatment. For patients who have a resection and who did not receive preoperative therapy, the panel recommends 6 months of adjuvant chemotherapy with either gemcitabine or 5-fluorouracil. It's important to note that just in the past few weeks, a new randomized trial of doublet adjuvant therapy with gemcitabine and capecitabine was published. This should be addressed by the panel in a new update coming out shortly. For patients with pancreatic cancer who received preoperative therapy, the panel acknowledged that there are no randomized trial data to guide the administration of postoperative therapy, but recommended that a total of 6 months of adjuvant treatment, including the preoperative regimen, be offered. So if patients have received roughly a month and a half of preoperative therapy, then an additional 4.5 months of chemotherapy with either agent be administered in this setting. And finally, it's important to emphasize need for ongoing supportive care for symptom burden that may result either from the operation and or the burden of pancreatic cancer in this setting. The panel acknowledged that there are no data to guide surveillance in patients who have completed treatment of potentially curable pancreatic cancer, but that visits may be offered at 3 to 6 monthly intervals, and serial cross-sectional imaging should be conducted over a prolonged period of time. This guideline is the first guideline from ASCO regarding potentially curable pancreatic cancer and offers guidance to clinicians regarding selection of patients for therapy and appropriate pre- and post-operative management. Thank you for listening to this week's episode of the ASCO University Weekly Podcast. For more information, be sure to check out ASCO University's quarterly e-learning series on ASCO Guidelines coming in 2017 by visiting university.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.